the fact that I'm an ICU nurse, and I hope that is good enough for today. But to stop the video, and then you can start with a discussion. So this topic is quite a vast topic. It's trying to do a whole few years of training and experience into a few single hours. And it's quite a challenge to decide what to tell people and what not to tell you. So I'm sharing you my very subjective perspective here. And you may find that some people have other not negotiable views. It will be different for everybody. So if we look at ICU, although people are allocated one-to-one, and we have the perception that nurses are always busy working one-to-one. This thing pops up on my screen the whole time. We are not working one-to-one. We are actually a team that works together, and each one has got a specific task. Now, when you're helping out in ICU, you may find that you'll be allocated to a single patient on a one-to-one, or even two patients to one staff member basis. Or you may find that we will now, in the disaster situation, switch to a task allocation. Whatever the system being used, we still work as a team. And you will take responsibility for your task being allocated, but you don't take total responsibility for everything that happens. It happens, decisions are made as a team. Now, who's our team? The team is the primary doctor who makes all the primary decisions for the treatment plan, and is predominantly the prescribing doctor. Tasks or patients will be allocated. The most important person on duty is the shift leader. The shift leader is the one who supervises and advises as we go along, and all decisions that we do take are checked and verified with the shift leader. There are various other people, the pharmacists, the dietitians, the physiotherapists, they're all essential part of the team, but they come and go. And you'll be surrounded by the nursing staff most of the time. In this scenario of COVID, where you are dealing with PPE, there's no devices that can show you who's a registered nurse or who is a enrolled nurse. There's no distinguishing devices, and you may want to know the names of the people around you and name badges. Most decisions are team decisions, so make sure that you discuss with the shift leader. Her role or responsibility is to support and assist. Now, what do nurses do in ICU? We can keep ourselves busy with 12 hours of discussion, but if I want to summarize it, I can do it as such. The main reason why patients go to ICU is for monitoring. Excellent monitoring will lead to a situation where we have early recognition of problems. And the point is early intervention. Monitoring has no use if it doesn't lead to early intervention. While doing that, the only thing we can do is to maintain the bodily functions, prevent complications, and allow healing to occur. There's no magic healing that happens in ICU. In the time we administer prescribed treatment, now that can vary from medication to dialysis to ECMO. We administer what needs to be given to the patient. Emergency preparedness is a golden thread that you'll hear straight through. We are always prepared for an untoward happening. And everything is embedded on a bed of safety. Every decision is based on safety of the patient. I shall give you a short timeline of how the day goes. And I've adapted a bit for the COVID situation, and you'll see soon. I'm talking from the premise that most people will go and work in a unit that they may be familiar with, but it will be a new task. So obviously our day starts with donning of PPE. Now, handover normally occurs at 6:45 to 7. That short time of overlap between the two shifts. Donning PPE can take up to half an hour. Now, in order not to lose handover time, I suggest that you come a little bit earlier and give yourself time to don all the PPE, and it will go faster as you get better at it. the critical thing is you don't want to miss handover. If you are new to the unit, try to be even earlier or even the previous day come and get yourself orientated to the unit. Even the unit you know is changing at the moment. There's go zones and no-go zones. And it doesn't work the way it used to work before. So just go and orientate yourself how things have changed in the time of a disaster. So handover is your unique opportunity to talk to the nursing staff and get a handover about the patient. You'll get an orientation about how it's been and what's important. And that's your time of sorting out what is to be done, what has happened, and what you can expect. It's the basis of your day starts with a good handover. In general, what I do next is I do a first set of observations and set alarms. The reason for that is I need to make sure how you are hemodynamically so that I know how the rest of the day is going to proceed. I cannot turn my back on the patient for all sorts of duties unless I know how stable or unstable he is. And I've set the alarms so that it can call me if there's a problem. I'll talk about alarms a little bit later. The next thing is the environmental check. Now, all of this happens before 8 o'clock, between that golden hour between 7 and 8. The environmental check is important, and I'll also spend some time on that. Remember, I talked about safety and emergency preparedness. And it is important that you set up your environment and you just orientate yourself to what you're having there. The next thing is an assessment head to toe of the patient. Some people use a systems approach. Whichever approach you use, you need to know exactly what's below those sheets. You need to know exactly what's happening with the patient and familiarize yourself with the patient. A device check is included in the assessment. Now, the devices are not only the machines next to the bed, it's how they connect with the patient. And we are mostly looking at our insertion sites. The insertion sites is important. Let's look at what goes in and out, what is the drain. Very important to establish where's the tip. That may need you to look at the x-rays at a later stage, especially with drains. You need to know where's the tip so that you know what you're draining. You need to look at the insertion site, what's the depth of insertion, and also if the device is secure. You all know how difficult it can get when the devices pull out. Very important next step is medication planning. Medication is a big part of what we do, and it can be very laborious and time consuming. Medication planning does not only involve a plan of what do I administer at what time, it also involves checking your stock, knowing that I need to order more or less, and figure out more or less how much time it will take. For patients on inotropes and large amounts of medication, you can easily set apart an hour or two per administration just for mixing and get yourselves ready. So that can be quite laborious, and careful planning is required, and you may need assistance in the beginning with that. Then starts the routine, hourly observations, nursing care, pressure care, mouth care, catheter care. I haven't even added eye care there. Bath and linen change, observations, medication, suction, physio, linen, hourly observations, and then the day starts that way. Now, COVID brings its unique challenges to ICU nursing. Patients are unstable. Now, normally we have quite a nice mix of unstable patients, and you have unstable and more stable patients. What COVID does is it's put the whole unit in a situation where the patients are all unstable and actually require specialist care. That means the monitoring has to be ever so careful, and the mixing of medication can be something that takes a lot of time and effort from you. All of them are ventilated. Proning brings its own challenge. Think of pressure part care, pressure injuries, number of people required for turning, and we're already running short of staff. So proning, which is a critical treatment modality, is bringing a lot of challenge. We hear a lot about the diarrhea, which increases the workload and can be quite a challenge if you have more than one patient. The COVID virus is known to have its neurological problems. Confusion and delirium is there, not only the conspicuous ICU syndrome, but also the injury from the virus itself. Pain is also a problem. We all know most ICU patients. The lingo goes that all patients are in pain until proven otherwise. And we also know that the COVID patients complain a lot about body aches and pains. Glucose control is quite a challenge at the moment. We visit with a large amount of diabetic patients, and in the sepsis, the glucose is becoming a problem, which brings us to hourly glucose measurement and insulin infusions. Now, insulin is part of the group of medicines called the A-pinch medication, and they are it's an acronym that has been put together for high-risk medication. Not only high risk for error, but also high risk for harm. And the I in the A-pinch stands for the insulin. The A is antipsychotics and antibiotics, potassium, insulin, narcotics and sedatives, cytotoxics, heparin and anticoagulants is what the rest are. The only one we are more or less saved from is the cytotoxics. The rest are stock in ICU. Also, these patients have prolonged intubations and ventilation, and I'm not only talking about many ventilatory days, I'm talking about the fact that intubation doesn't take as quick as it used to. It is now a longer procedure. Cardiac arrest during intubations, also sudden cardiac arrest is known to happen, and we have to be awake. Supplies in the unit at bedside. I'm not saying that we're short of stock. It is just a challenge to get everything at your bedside, considering where you can't go with you without your PPE. And depending how the unit is laid out, you'll have to plan carefully for that. Now, who's who? I see there's a question of the role description and role and job description, and we can do that. But for starters, let's talk about who is who. And the rule is, if you put your signature on the ICU chart or on a document, we need to know who that signature belongs to. Now we don't particularly enjoy paperwork, so the ICU charts are developed in such a way that it is a lot of the unnecessary writing is taken away. So I suggest that one of the first things that you do is you identify yourself in the morning on the charts by your designation, full name and surname, your initials and a full signature. And thereafter, your scribble called initials only would suffice because we know who it belongs to. If we go to task allocation, that is a challenge, but please take aware that everything that is done should be recorded. I talked about the environmental check. This is also something that you don't have to remember. We've put a short checklist on the back of the ICU chart. You don't want to look at that the whole day, but at least early morning when you're sorting yourself out, there is a checklist to check that everything has been done and prepared to ensure that the patient's in a safe environment. I've just highlighted with red here a few non-negotiables. One of them are the ID bands. We have lots of new people in the units. Duties are allocated in ways that they've never been allocated before. And a patient that the patient needs to be properly identified. It's not negotiable. If you can't read it, replace it. We need to know exactly who's in that bed, and we also need to know what documentation belongs to that patient. ESCOM and load shedding is upon us again, so make sure your electrical devices are plugged into the UPS. Luckily, these plugs are nicely marked. You will know exactly which one. And the life-saving devices should be plugged into UPS. The others could be in plain generator power, and the batteries needs to be charging. We cannot take a chance on that. And it's well marked, and you should be fine. Like, just check that they switched on. You don't know how things can go wrong when you would never expect it. Suction unit working, non-negotiable as well, and we'll normally just check that quickly. Back valve resuscitator needs to be checked. It should be available at the bedside, one per patient, and the mask should be the correct side. We normally use the disposable back valve resuscitators, and at least that makes it much easier. It's labeled, it's for a specific patient, and one have a safe assumption that it should be workable. If not, just check. If you're concerned your patient is going the wrong way, just check a little bit before the time. Another very important aspect is the vacuolators and the lines that needs to be labeled, and I'll spend some time with that today. All part of emergency preparedness and safety. Very lousy duty, but very important, is environmental dam dusting. And in a situation like we are in now, dam dusting has actually increased in importance. You've all seen these pictures. It's been all over the media and social media on the persistence of the viruses on various surfaces. All these surfaces are well represented at your bedside. And you need to clean the environment, and you'll be supplied with a cleaning material to reduce the viral load in your environment. We touch everything all the time. And it will be a good time to consider what you touch. Just a brief look at the high touch areas, and it's not the things that we always think of. Yes, we always touch the monitor and the equipment, the IV pole, blood pressure there, cot sides. I miss an arrow here at the cot side. People often hang on the beds. Please get out of that habit. And there's a lot of areas that's often touched that we need to clean quite properly. And the notorious stethoscope. We would advise you clean the stethoscope for your own safety, your own ears, especially if there's a shared or communal stethoscope. If you bring your own, clean it properly between patients, please. Now, what is ICU about? ICU is about the monitor and monitoring. So I'm going to stop a bit here and spend some time on the monitor. On the first line, we see the ECG monitoring, the ECG tracing. Now, by pure convention, it's normally generally in green and on top of, and the top row. In this case, you can see the patient has got a heart rate of 104. What you can see here in small numbers is actually the alarm limits. Now, the educator in me is not particularly impressed with 160 over 75 as alarm limits, but it is here to show a point. That is very large, wide limits, and we'll talk about it. Then you record the rate on the ICU chart, and I'll show you briefly where it's recorded. If you're comfortable with rhythm analysis, please do so. If you're not comfortable, rather leave it open than to merely copy from the previous hour. And that is the good old-fashioned heart rate. The next one is the peripheral saturation. And this patient is in a good shape. His peripheral saturation is 100%, which can be seen as over-oxygenation with the latest information that we have. The saturation is normally this turquoise color, or some units make it purple. And it's quite clear which tracing will be the saturation tracing, and it's obviously labeled peripheral saturation. And saturation is now the big talk all along, and it's a major decision maker in the care of the patient. This patient's alarm limits are 100 over 90. 90 is quite low. I would like to know before 90 if my patient's saturation is dropping. I would be very uncomfortable if his saturation dropped by 10 without me noticing. What the importance of the tracings? You cannot trust the number if it's not a good tracing. Now, tracing analysis, it takes a few days of adequate study of the hemodynamics and the cardiac cycle to understand them. So let us just say that if your tracing doesn't look regular like this one, all of them more or less the same, clearly linked to the ECG. Every peak is linked to a QRS, then that is probably not an accurate reading. We're not nursing the numbers only, we need to look at the tracings to verify. Now, this patient's got an arterial line. And you can see the arterial line tracing. If there's an arterial line, it's got to be transduced, and you've got to see the tracing, considering the dangers of arterial occlusion and limb injury. This patient is in trouble. His blood pressure is 73/33 with a mean pressure of 46. Now, we've all been trained in blood pressure 120/80. In ICU, that is good to know, but our focus is on the mean pressure. And in general, the plan is for the mean to stay above 65. And if all alarms fail, this alarm is not negotiable. We make our decisions based on the mean pressure and thereafter the systolic. Most patients may have a central line and it may or may not transduce the CVP. It's not seen as the most important. There's a lot of people who don't measure CVP anymore because it's not particularly accurate in fluid prediction. If your patient's on IV fluids, you may find that this port is being used and then we cannot record the CVP. And it's a team decision to decide how important it is that you should see it every hour or should record it every hour. The last bit on the monitor is the respiratory rate. Now it's actually the ventilatory rate, and it is notoriously inaccurate on these cardiac monitors. It is the weak point of all cardiac monitors. It has been improving. Maybe I'm an old nurse, but I don't particularly trust it. I find it too often to be incorrect. Patients on a ventilator, it's acceptable to ignore this one and consider the ventilatory rate on the ventilator only. Patients not ventilated, this becomes quite useful. Again, a point on alarms. This one is set at 30, which I would require. This is a good setting. From 24 to 8, this patient is basically apneic before you will notice, and I will talk to you about alarms. But just to give you an idea that the alarms are visible in front of the monitor and it guides you. Remember, the function of the alarm is to call you when you're elsewhere occupied, you're not noticing that the patient is changing condition. Some monitors, some units measure temperature continuously. Some of them has intermittent temperature monitoring, and you will see how it goes in each unit. So let's talk about those alarms. I think the first thing that we need to talk about is that you can temporarily silence the alarm, and that's what you will do quite a lot. You only do that if you know what caused the alarm and you're busy dealing with a problem. And then you'll press mostly a yellow button on most types of monitors, and it's the alarm signature with a line through it, and it blocks it temporarily for 2 minutes. And as I say, you cannot block the alarm unless you know what caused it and you are busy dealing with it. That is completely acceptable. When we turn a patient, there's a lot of disturbance, lots of alarms, patient is coughing. To have alarms completely blocked is a different story. And you can see that on the front of this monitor, you'll have this sign. Instead of the readings to say what my alarm limits are, you will see this sign, and that is not acceptable to see it. Maybe a little tolerance for respiratory rate if it's a ventilated patient, but it differs from unit to unit. In this case, there's a non-invasive blood pressure, 102/82 with a mean of 86. There is a bit of a history. This is taken automatically. So the purpose of the alarm is to tell you that the patient is changing condition. It's not there to tell you that the patient has just had a cardiac arrest. And setting these alarms is tricky. If you make it too broad, like the 160/75, you run the risk of not noticing that your patient is changing and that there's problems starting. And you're not reacting early enough. If you make them too narrow, that causes nuisance alarms. People become overwhelmed by the alarms, desensitized to the alarms, don't respond to the alarms. And we've all been in that units where it's a noise all along based on the alarms. And it's because of very narrow alarm settings that the people become desensitized to the alarms. So the trick is to set your alarm so that you are aware when your patient changes, but not too late, and definitely nuisance alarms. Now what we have here is a saturation of 100%. We're very grateful for that, but we must know our target for COVID is 92 to 96. There's lots of talk about hyperoxia, and the days of 100% is probably over. What you have and what you want are not always textbook values. And that's where the problem comes in. It's quite difficult sometimes to decide what is an acceptable value or something that's got to be corrected. And my students will recognize this. The most dangerous alarm is the one that you ignore. It's always the one that's going to come back and bite you. Record keeping. Now, the ICU chart is developed in such a way that it actually limits the writing, where you can tick and dot, and you actually put a lot of information on the chart in as short a space of time as is available. Now, if you're not familiar with the chart, it's quite daunting to find this right spot to record what you want to do. So on the back of the ICU chart is a flow chart. If you don't know what to do, where to write something, just start writing it there, time and sign, and then record keeping is dealt with. But let's look at the record keeping vital data and Muse. Here's a snip from the ICU chart, and if you don't know what to do, just start on top and run it through, and you'll probably miss very little. You may not understand the abbreviations, but we will miss very little. The chart is developed in 7 o'clock, 7:15, 7:30, 8:45, 8. Quarter hourly increments. This is blood pressure, heart rate map all in one. You'll see there's your guidance. And as I said, the map is quite important. Heart rate, cardiac rhythm, only if you're familiar and certain with the rhythm. And there's some authorized abbreviations that you can use, and the rest of the chart follows down. Now, right at the bottom is the neurovascular observations. No matter how important and how fancy our machines are, the neurovascular observations are one of the earliest indications that your patient is going in the wrong direction. And you need to record capillary refill in seconds. 1 second, 2 seconds, 3 seconds, 4 seconds. It's actually quite easy. There's no fancy way to it. And we record our capillary refill like that. You need to touch your patient every hour so that you can feel his skin temperature, feel the pulse, observe the color of the peripheries. Sensation and movement may not be accessible when the patient is sedated and paralyzed. So some of the most important observations, that's early indicators of patients going the wrong direction, is actually not shown on a machine. It's shown on the patient's body. And it brings us back to the whole scenario of nurse the patient or care for the patient and not the machines. They are useful, but all the answers are not on the machine. Now, observations are done mostly hourly. If the patient's unstable, obviously more frequently. Now, COVID is known to bring us patients who suddenly change condition. We've heard about cardiac arrests, patients fine, half an hour later cardiac arrested, frequent cardiac arrests. So it requires extra vigilance, but we should say hourly observations at minimum. Saying that, don't forget the unmeasurables, which is not even on the chart, but you should take note of your patient, and that's your connection with the patient will show this. I'm talking about a patient who's increasingly tired, whose work of breathing is increasing. A patient who's stable, a patient who's breathing normally and comfortably. You shouldn't see a patient breathing. Breathing is not something that you should notice. If you notice it, it's wrong. And it can get wronger as the day goes. So observe not only how often the patient breathes, but how he breathes and how much effort it takes. And an increase in effort is definitely an alarm bell. Very important to talk about the high number of words when the patient can talk to you between breaths. And that will be an indicator where we're going with this patient. So a lot of the important information is not on the machines, it's not on the chart, and you need to be aware of that. Now, this is the Muse Score. It's a modified early warning score. This for different age groups. It's a risk assessment score. It's not often used. In fact, it's not used in ICU at all. It is to give the ward staff an indication of when is it time to escalate the patient's care. Now, they escalate it to ICU. We can't escalate it any higher. And we actually normally work with expected outcomes of the patient. You know what you want for the patient, what is acceptable, what is not. And those are not always textbook values. But this is a very useful guide for the ward staff to say this patient is now needing an escalation of care. Now, I've highlighted here in red, it's 10 points that the patient is scored on. And I've highlighted in red here the admission criteria for ICU, for COVID, when the recommendation is we need to start ventilating now. And you'll see the patient's already in a score of 5. Now, by a score of 3 means start getting the ICU people involved in the decision making. So patient's in the right place, it's an ICU, he's got a score of 5. So what's the use of saying we should use the Muse score at this moment? When you have people that's unfamiliar with the whole patient and the requirements, the Muse is seen as a nice way of telling you where you are heading with this patient. There's no number that's a normal number. The perfect number is 0 for every patient. And I would recommend, if you're unsure where you are and you do a Muse score on your patient, a change by 1 needs to be reviewed and the care may have to be adjusted. You'll see the heart rate. They often go to heart rates of 120, respiratory rate in the higher 20s, responding drowsiness, responding only to verbal stimulation. Saturations are on the low side and they are already on oxygen. So if you're looking after the patient and you do the Muse score and the patient's changed by 1, it is something that needs to be addressed. All patients in ICU are anxious. They know, they've read the newspapers, they know that there's a chance and there's a high mortality involved once you get into ICU. So they are aware of that. Even before COVID, patients know that ICUs are places where people die. So anxiety is a very important component to address. Problem is, with a respiratory problem, we can't always deal with that with medication because that will suppress the breathing. False hope is not a way to get a patient quiet, and calming your demeanor will often be more important here in dealing with the anxiety. And that is a challenge for all of us, how to deal with an anxious patient and answering all their questions and do so honestly. Delirium is known to occur in COVID patients due to direct viral injury, but also the notorious ICU syndrome. So we know about patients being delirious. Delirium carries a very poor prognosis, and we need to report and deal with that. Now, how do we assess the patient neurologically in ICU? Now, for some of you that's paramedics, you are very familiar with the Glasgow Coma Scale, and it takes some getting to know it. It's got its limitations, and it's not the easiest score to do, and there's often disagreement on Glasgow Coma scores. But the Glasgow Coma score is not successful for ICU patients. It is not sensitive enough, and it does not pick up, Caroline, I see you, I'll get to you just now. It is not particularly sensitive, and it doesn't show us when the patient is changing his condition. And we know that Glasgow Coma Score is known not to be effective and not recommended in sedated patients. Our patients are sedated. So the Glasgow Coma Scale is there. It's got its place in neurological injury, but otherwise all ICU patients are assessed via the Richmond Agitation Sedation Scale. I'm going to finish this and then I'll give Caroline an opportunity. It's a very easy score. It doesn't require particular training, but it is a very early indicator of something going wrong. All goes well, the patient is alert and calm. We've all learned at school that one of the first signs of respiratory distress is restlessness. And here we have a place of scoring restless, and you can read the description. Apprehensive, but not aggressive nor vigorous movements. Patient's getting agitated now, and there's non-purposeful movement or ventilated asynchrony. And then the score can increase. And I have more than I can care to remember seeing how the patient's score changes before the patient's hemodynamics changes. The patient can go the other direction, being the more drowsy direction. And this is often missed because we're just so happy the patient is settling a bit. And it's not uncommon for them to go from agitated and restless to drowsy, which is actually quite a bad sign. So when we sedate a patient on a ventilator, we normally want a -2 to -3 sedation, where the patient does connect with the environment, eye contact or no eye contact, but he's not completely flattened out or anesthetized. So that is normally the aim. Normally when we admit a patient, settling in, intubating, drains, starting to get control of the hemodynamics, we do put them on a score of -5 so that we can get into control, and then it gets gently lifted so that the patient is moderately sedated. Deep sedation is known to contribute to delirium, but also in the awake patient, the non-intubated patient, this is an early indication of harm. Caroline, do you want to type your question or do you want to ask it verbally?
Gloria, it seems like her microphone isn't connected to Zoom, so she'll need to just type the question for us, please.
Okay, well, I'll answer it when I see it. Thank you.
Thanks.
So we've talked about delirium, but let's talk about the everyday occurrence of something called pain. Every patient in ICU has got pain. ICU is uncomfortable, and we know that COVID causes bodily aches and pains. And you all know how you feel after a day in bed if you've had flu, and now you put the patient into bed unlimited. So the patients don't particularly enjoy being in ICU. And pain is well described as a very bad negative consequences, even causing post-traumatic stress disorder on its own. Now, if you look at this patient, it's unfortunately not very visible, but you can see him lying down there frowning. This is not acceptable. And unless you have evidence to the other, please accept that this patient is in pain and we need to deal with that. We can all talk about the ethics of leaving a patient in pain, and also physiological. There's good reason pain harms the patient physiologically. So we administer analgesics routinely, aggressively, so that the patient is not in pain. It's easy to assess pain on a patient who's awake and can tell you on a score from 1 to 10 how bad is his pain. And on the ICU chart, it's like a spot, and you record. It's a 1 out of 10, a 2 out of 10. And the patient tells you it's 4 out of 10, giving him his painkillers, his analgesia, comes down to 2 out of 10 and job well done. But what do you do with a patient who can't talk? Now, there's a score that we call the CPOT score. It's developed specifically for ICU patients. It's a critical care pain observation tool. And you don't have to learn the tool out of your head. It's printed on the back of the chart. You can find it there. And you score your patient and you give them a score of 2 or 3 from the score of 2 of higher needs urgent intervention. And that is based on your observation of the patient as you're working with him. Gentle touching of the patient shouldn't provoke pain. But when you work and he's frowning heavily, they resist heavily. A little bit of resistance is normal, but not a patient who resists heavily. And your CPOT score is based on your observations, so when you're working with a patient. And just a word of warning, be careful of the patient who don't move at all, because he doesn't move because he has pain. And you need to just be aware of that. So pain, we assess for it, we manage it, and we make sure that our assessment was effective. As I said, most of what we do is medication. I see Thomas Meyer raised a hand. Before I continue.
Thomas, I've unmuted you so you can verbalize your question. Thomas, are you there?
Okay. We shall answer all those questions at the end. Now, as I said, most of what we do is medication. Medication is mostly what is required to solve the problem. Remember, ICU is supportive, we don't solve the problems. And I cannot emphasize enough the importance of correct identification to make sure that your patient match the RD-band match the ICU chart, it correlates with the patient's file and prescription forms. It is a common source of medication error, and even in a controlled environment as ICU, it happens, and I'm sure our controlled ICUs are becoming more uncontrolled, and we need to be careful about this. So, there's the 8 rights of medication administration. You don't have to remember them. They're quite intuitive, although important. And it is about giving the right medication to the right patient for the right reason. I think it stands to reason that if the patient is prescribed daily potassium replacement, but today the potassium is 5.5, that you are not going to give it. So it starts with the right patient, right medication for the right reason. And double check the medication. Lasix and Losec sounds the same, it looks the same, but definitely do different work. Make sure it's the right dose. And I'm going to say this a few times, it needs to be double checked. Right route, right time. And I'm not only talking about the time of administration, I'm also talking about duration of administration. Short infusions can be anything from 2 minutes to 30 minutes, and you need to make sure of what short infusion means. Right documentation, and then to anticipate and observe for the correct response. I'm giving analgesia, I expect an improvement in the pain. Here's our lines. This is what we do a lot of the times during the day, and I want to draw your attention to a few things. Firstly, this is an enteral feed hanging here, and it goes through a specially designated pump. The principle is food and IV should never be mixed. Now, environments in such a situation that sometimes you have to do it like this, but we shall never give a food via an infusion pump. And you'll see there's different pumps for a very specific reason. You do not want the nasogastric food on the intracentral line. Another important thing to notice that even though I don't have a picture of it, there's a TPN pump. So although that's IV administration, it still carries risk and should be on its own. So you'll find that food-related administration is always in its own pump, be it enteral or parenteral. If you look at the labeling, it looks like we're doing a lot of labeling. This looks quite a mix of bags, and you need to make sure what's happening. Every bag is labeled with what's in there, or sometimes just to say there's nothing in here. Then it goes through the pumps, and this pump is labeled via the drug library. David spoke about it before. It's pre-programmed to say morphine, so many milligrams in so many mils of fluids, and you choose the right program, and you can look at the pump and says which one's the morphine, and it will display morphine, adrenaline, dormicum, Presidex, whatever being administered. Plus, every line is labeled with a day when it was started. Lines are normally changed at 72 hours, so you need to check when should the lines be changed. And just a note, all these lines is not always at the same time. It's good because it's a lot of work to change them, but also it means that you need to be quite aware and check all your lines. We normally change them when we change the vacuolator for any reason. And you need to change the whole line because that is associated with bloodstream infections. So the vacuolator is labeled, the line is labeled, the pump is labeled, and when we get to the patient, you'll find this is the zone of error, and there's labels there as well. Wrongful administration, wrongful mixing, mistakes happens at this zone, close to the stopcocks. And the zone of error should be clearly marked. And different units has got different stickers. There's standardized stickers available. And it's just a question that you do not want to give a glucose bolus in the same line as potassium or even your adrenaline infusion. And as I said, this is the zone of error. And David spoke about the stopcocks before and said, please make sure that you know how they work. I cannot emphasize that more. The rule is generally that there should be a port available where you can administer emergency medication. A good example is when the patient is hypoglycemic, you need a port for glucose. The patient is vomiting, we need to get antiemetics in, or a bolus of adrenaline. There should be a port available for emergency bolus administration. That sometimes happens with a central line, and just make sure that what flushes with it. There's a common way of doing it in all the hospitals. It may vary per individual hospital, but in general, the rule is that all inotropes run on their own and separately, because you cannot afford a flush of adrenaline of inotropes or it accidentally being closed off. It's not to be used for anything else. Brown port or blue port is for the central line, can be used for the CVP readings and for intermittent infusions. And the white port in the central line is normally reserved for TPN. When we need it, we use it. But if we have the luxury, we will reserve it for TPN. Now, this changes amongst hospitals, where the white port is used for medicine and the brown ports are used for TPN. Labeling is quite important. What you don't use, discard of it so that it doesn't make it such a mess. And being very careful that whenever you touch a line, open or closed, it's absolutely aseptic technique. The ports and the connections has been shown to be a significant contributor to bloodstream infections. So that means that when you open and close, you need to have an alcohol swab, wait your 10 seconds and reconnect. And I've already said, don't use something for what it's not meant. Please do not put IV fluids through a food pump or food through an IV pump. Medication. And medication is completely different from what most people are used to. All the patients have IV lines, and they got to get a line, and sometimes they will have multiple lines, and central line may be one of those. And when we administer medication, that is a good time to do a site check. The line must be patent, and the insertion site must be not inflamed or bleeding. Now, nobody checks it every hour, but when you administer medication, that is a good time to purposefully observe your insertion site. It's not unusual to get the 48 ampules of adrenaline in 200 ml saline. That's normally the recipe we use. In fact, it's 152 ml, so that the constituted volume is 200 ml. Now, the reason for the quadruple, I've heard the question before here. Quadruple strength, it doesn't matter whether it's single, quadruple, or 10 times the strength. The problem is you want to give, it's about the dose. You want to give a high dose, but you don't want to give the volume required. Now, if I put 1 ampule in 50 mils, by the time I get the adequate dose required, I'm using like 40 amps, 40 vacuoliters. So the patient obviously cannot afford all of that fluid. So that's why we use it double strength, quadruple strength. It does not matter. The risk comes in if you use the wrong protocol and the wrong drug library. The stronger the concentration, the smaller the changes you need to make. But this is often what we do, and you can imagine how long it takes you to break open and draw up 48 amps of adrenaline. And sometimes you need to do that very often. The rule of safety here is that you calculate more or less when your IV will be finished, and you need to make sure that you mix the next bag 2 hours before. There's dose increases that may occur, and these patients that are on high doses of inotropes, like our COVID patients, are in septic shock. Even the bag change drops their blood pressure. You cannot afford that delay in changing the bags. So it's done in advance, labeled, ready at the bedside. When the machine says, the IV pump says that the infusion is finished, you change it immediately. Analgesia. Now here's a little dose, morphine 5 mils in 45 mils of normal saline. It's a very low dose, and the patient gets for low dose analgesia. Now, when we get to trauma patients, surgical patients, we often go much higher dosages. And in some units, they would draw up the morphine neat to 90 milligrams. So please make sure of the dose that you have in the bag. It can be 1 milligram per milliliter, it can be half a milligram, or it can literally be a very strong, neat, undiluted morphine. And all I'm saying is check, 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 be careful. And the stronger the concentration, the smaller the changes you need to make. Double check your calculations and formulas. I would not advise anyone to administer medication on its own. When I was a young ICU nurse, I was bright and brave. I did all of that on my own, and I've learned through the years there's more harm in that. And the older I'm in ICU, the more I'm checking. Double check everything, use the protocols. This is not the time for maths. Use the protocols, double check, double check, double check. The chance for harm is too big. Now, everything that you see is not IV lines. If you look at it, these look like IV lines, but they're not. This is a heparin flush connected to a flush bag, and that is what we normally use in our central lines and on the arterial lines. You can see there's a pressure gauge, and the pressure should be kept in the green. But it's not an IV line, and we do not administer anything. Yes, it's connected to the vasculature, but it's not an IV line the way that you're used to it. And please pay notice to the notices like not for IV use. This is water for humidification that's attached to our oxygen devices. And you do not want water in the veins. So please heed, everything that looks like intravenous medication is not intravenous medication. So record fluid and intake. For those of you that's heard it before, every ICU patients on very strict intake and output. Every drop counts. And we record everything that goes in or out of the patient. It's also an hourly assessment. And there's 2 blocks. Record what is the infusion running, blood, platelets, antibiotics, how much is the volume, and that's normally recorded in black. And the second line is for dose. Volume is important because we consider that in volume decisions. Now, understanding that the patients here are on a very slippery slope concerning volume. To dry and we lose the kidneys, to wet and we lose the lungs. So volume needs to be accurately measured. So the volume, and at the end of the shift, we'll add. At the end of the day, our decisions on medication and treatment is based on dose. And we generally record the volume and the dose related to every infusion that goes into the patient. We need to know that if the 2 mils of morphine is that 2 milligrams of morphine or 20 milligrams of morphine. And that's recorded here in red, and we generally don't add that up. Now, if you look at the output, everything that goes out is measured, hourly urine, nasogastric drains, everything that leaves the patient is measured. Just a word of advice, I've seen errors in this regard before. We have different measures. This is the urine measuring, and this is the one that we use most commonly. Hourly urinary measurement, you write exactly how much milliliter of urine the patient has passed in the last hour. It's emptied into the bigger bag, and this bag we normally finish empty towards the end of the shift. And if your patient has diuresis, you need to be awake and empty it more often. When you empty, at least with the PPE we wear recently, splashes are not such a big problem, but please be careful and ensure that you don't touch. It's very non-touch technique. And we clean this before and after because we don't want upward migration of microorganisms. So, in conclusion, the safety rules. Pay attention to details. Small things matter. If you don't know, ask. Do not assume anything. Use ICU. And it doesn't work like that. If it's not written or documented, it was not done, sign for what you've done, not what somebody else has done, what you've done yourselves. If it does not look right, it probably is not right. Don't think that you're inexperienced, your observations doesn't matter, it does. Everything has to be checked with a shift leader or the designated person. I thank you for your attention. Any questions?
Thank you so much, Gloria. That was extremely informative and definitely a bit eye-opening. I think we underestimate how much ICU nurses actually do and how much activity actually happens in an ICU. As a reminder, you can either raise your hand or you can type your questions and then we'll try and address it and pass on to Gloria. Thank you.
Chris, it's Mandy. Can you hear me?
I can.
Thank you, Gloria. Just want to let you know that this is probably only one in the series. This lecture would probably take 2 to 2.5 hours. So we're going to do a second part of this lecture, probably around the 26th, or we might move other people around and give Gloria a slot closer sometime next week. So just there's a lot more that she would want to discuss with us.
Gloria, I see a question. It's not very detailed, but just to say blood glucose check-in. I'm not sure if there's some more details that Helen, I'm not sure if you want to add any more details to that.
Yeah, blood glucose checking is something that we will do hourly. I did not address that today because I'm going to do it next time when we talk about the eating and the feeding. But blood glucose checking is inevitably something that happens hourly because most of these patients has got deranged values.
I can definitely say that this is the most or the highest number of messages we received to say congratulations and well done and thank you. So that's definitely a compliment to take out of that. I do see a question coming out or a comment just to say, or no question, is urine dipsticks BD still important?
Yes, it is. We still do it, BD. There's a lot of decisions. Patients are known to get UTIs. We know that catheter-associated urinary tract infections is one of our biggest problems, and I think that still is the main infection, a device-associated infection in ICU specifically. And we need the nitrates. We need to look at the nitrates and the leukocytes to pick that up early because it's often missed. So just for a start there, we still do BD urinary tests. Well, I hope I've convinced most people to come and work in ICU.
Well, either convinced or scared. Hopefully. Okay, I don't see any other questions. It's a lot of appreciation. I think everybody's clearly valued this session. So the second session would certainly be appreciated and I think welcomed by all.
Yes, in the next section, we'll deal more with the ventilation and the care of the patient and the more basic, what we call basic, but most important care.
Okay, perfect. Thanks, Gloria. Mandy, or actually, Shannon, I saw you online. I'll make you a co-host. I'm not sure if you want to maybe add in a comment from your side. Shannon, you can unmute yourself if you'd like to make a comment. Not to put you on the spot.
Yeah, no, it's fine. Thanks, Chris. I appreciate it. Thank you, Gloria, and the team that worked on putting the presentation together. We really do appreciate it. I think even for people that are working in ICU, it's always a good reminder. And thank you for everybody who participated. If there are thank you, Chris, for the facilitation, and Mandy for managing the process as well. Thank you very much, everybody.
Always remains teamwork.
There's a very good question here, which I don't want to miss, Chris. It's from Karen Gibbs, which says, with the increased ratio to patient to nurse ratio, what are the legal implications of not being able to do the work that is required hourly? And maybe I can answer that partially, and then you, Gloria, as well. So I think that when you are working at surge and when you are in a disaster situation, you do the best for the most. And if you have a team approach to managing a patient and you are truly supportive of each other, nothing should really go undone. Everybody will have an opportunity to get the care that they require, but that is really reliant on the true team approach within the ICU and the scenario of doing the best for the most. So, you know, if you don't get to doing a BD dipsticks or maybe the food runs out for 20 minutes or you miss a glucose and you only do it every 2 hours because that's the best you can do, then you have done the best for the most. And I think that's the scenario that needs to be accepted in our ICUs. Gloria, I don't know if you have any other comment to that.
Yes, and we must remember that the principle is reasonableness. What is reasonable to expect in any situation?
I agree. Want to talk on fluid output and catheterization, Steve? Are you going to do that for me, or because you're the urologist, or do you want us to do it for you? Okay, I'll speak to Steve offline and we'll see what we can put together for him. Thank you very much, everybody. Corin? Oh, you can do it for me. Excellent, Steve. I'll phone you now. Okay. Chris, do you want to close?
Yeah, sure. Yeah, last comment. The lectures are all available on Netcare's YouTube page. You can just search for Netcare on YouTube. You'll see all our videos are uploaded. I'll try and upload this one tonight as well. And please do share the link to register with other people. Kind of spread it far and wide. The more the merrier. We're happy to have so many people on tonight. I think tonight we crossed 250, which I think is our highest thus far. And hopefully we'll have more and more people joining us. Otherwise, have a good evening, everybody. Thank you very much.
Thank you, Chris.
Thanks, Gloria. Bye-bye.
Bye.
Yeah.